Okay, here we go. Sure. So, yes, they asked me on Wednesday to step in for Dr. Bolins, and unfortunately, he had a family emergency, and I just kind of wish him well. But you are getting sort of second string here. So, if I can't answer the question, tough. We'll go from there. Okay, let's make this slideshow. There we go. Okay, my disclosures. I'm going to be talking about an overview of bone marrow transplant and gene therapy for adrenal leukodystrophy. This is the iconic view of Johns Hopkins, which is where I now work. I'm not showing you my dingy office, which looks out over a ventilatory shaft, but it is what it is. So adrenal leukodystrophy is actually a peroxisomal disorder, and that has a little bit of impact because much of the newborn screening that will pick up elevations in very long chain fatty acids. And so there's a whole group of assembly disorders which we'll also be picking up. And it's also important when we start to discuss bone marrow transplant because this is a different kind of disorder from some of the other non-hematologic transplanted disorders. But X-linked adrenal leukodystrophy is the most common peroxisomal disorder. It is an X-linked disorder located in XQ28. It has an incidence of about 1 in 17,000, unless you live in Minnesota, where newborn screening is finding out it's a public health menace. It's due to alterations in this peroxisomal ATPase binding cassette protein, ABCD1, which results in defects in peroxisomal beta oxidation and the accumulation of very long chain fatty acids. And as we've heard in a lot of detail, it affects the adrenal cortex, the myelin, and the testes. What's interesting about it and somewhat unsettling for the newborn screeners is that it has several different kinds of presentations. So about a third of individuals will develop this childhood cerebral form, with the other individuals probably going on to develop adrenal myeloneuropathy. And as the slide says, approximately 50 or not more of women will develop AMN type symptoms in adulthood. But this is what we're looking at. We're looking at childhood cerebral ALD, which is initially normal development. And then somewhere between 4 to 10 years of age, individuals start to develop kind of subtle symptoms. And before newborn screening, they would have to come to someone's attention. And this would often be very hard because they look like they have ADHD or they get, having some vision and seeing the blackboard. And unfortunately, it progresses rapidly to a vegetative state. And so this is what the classic MRI looked like. But as Dr. Malak had pointed out, it's going to be changing over time. So that what we're looking for when we talk about transplant is, small changes in the corpus callosum, which progress over time. And as Eric, showed beautiful data on, it does so gradually, and this is the point of time when we want to start looking at treatment. So what is this thing called hematopoietic stem cells therapy? Well, it replaces the affected blood forming cells with new ones. And so as you can imagine, this is predominantly used in hematologic disorders. So these blood stem cells are immature cells that grow into red blood cells, white blood cells, and platelets. And so for individuals who have disorders of red blood cells or white blood cells or platelets, we can give them a new marrow and hopefully correct those deficits. And when they mature, they leave, they become all of these full-grown cells, which we see here. Well, there's a few other things you need to know. So it's not a surgery. I mean, oftentimes we talk about transplants and people go, well, that, like giving a kidney or a liver, it's not surgery. The stem cells actually do travel through your bloodstream through the intravenous route. They travel home to the marrow. So what we see on the cartoon here is that they're collected from a donor. They're processed. There's conditioning that has to occur. They have to make room for them. And so that's the chemotherapy In some instances, that used to be radiation. We don't use radiation so much now in adrenal leukodystrophy, but it is used in other types of transplants. And then they're given back to the patient via, basically an intravenous catheter. And then they home into the marrow itself. The stem cells can come from someone else's bone marrow. They can come from peripheral blood stem cells, something called, they mobilize them, and then they collect them. And they can also come from umbilical cord bloods. And so they basically get these placentas, and they milk out the blood in them, which is full of stem cells. And these fetal cells are very active and very able to make new blood cells. There's essentially two types of transplant. There's an autologous transplant, which is using your own blood-forming cells, and that's used predominantly in certain forms of leukemia, lymphomas, where you're trying to give people high-dose chemotherapy and then rescue them, but also treat them. And so there's lots of protocols using for autologous transplant. There's also allogeneic. Meaning someone different. It can be a family member, typically a sibling, but we'll go through some other individuals who it could be, or it could be an unrelated donor. And we'll talk a little bit more about that towards the end. We're presently able to treat over 70 different conditions. Most of them, as I said, are blood diseases and cancers, but also immune and metabolic disorders. Well, how did this non-hematologic genetic disorders come about? It came about because in the lysosomal, which is a completely different organelle and a completely different set of genetic disorders, but in the lysosomal field, it had been known from the 70s that if you co-cultured cells that were healthy with disease cells, something was secreted by the healthy cells to be taken up by the disease cells and correct their deficit. So this was called co-correction. And then Hobbes in England reported his experience with a completely different disorder again, Hurler syndrome, I believe in the early 80s, where he treated a boy with Hurler syndrome, and it corrected that individual's progressive disorder. And that started this whole process of looking at metabolic genetic disorders to try and treat them with bone marrow transplant. And in 1984, I think it was probably 83, when the paper came out in 84, that was actually done at Johns Hopkins with an individual with bone marrow transplant in adrenal leukodystrophy. It was a boy with early cerebral disease with spasticity, but also already some severe auditory processing defects. So already somewhat symptomatic when he had come to attention. This is I know this kind of image looks a little different. This is what's referred to as a CT scan. We don't use those for monitoring for adrenal leukodystrophy that often anymore because it has radiation, but we can also get better images with MRI. His donor was a sibling, and he engrafted in 4 weeks. However, he quickly developed visual loss in the first weeks, and his neurologic condition worsened, and he died at approximately, he died at 144 days into his transplant. He got an overwhelming infection. This really put this was very concerning to the group at Johns Hopkins. It was like, how are we, is this even an option? Is this something we should be doing? In 1990, Patrick Aubourg in Paris did a slightly different take. Now using MRI, they could see this early lesion. You can kind of see, these little white dots. There's a very small lesion here. And again, they transplanted an individual at this stage, and there was an arrest of his disease. The paper actually says it's a reversal. I think you can kind of squint and wonder if there might be some reversal, but it really is just an arrest of the disease. And I believe it was a sibling donor again. which all becomes very interesting because this was prior to our knowledge of what the basic biologic defect it was in adrenal leukodystrophy. So in that lysosomal field, we know that these enzymes get secreted, they get taken up by cells now, and we actually understand that mechanism. In the peroxisome, ABCD1 is a transporter. It is not something that gets secreted. And in fact, it is something that transports the very long chain fatty acids into the peroxisome to get metabolized. And there's really no way this is getting secreted from one healthy cell to another. So cross correction is not the mechanism of action. I have some thoughts about what the mechanism of action is, but be that as it may, at this point, we do not know for certain. So, but it has led to our continued use of hematopoietic stem cells. Again, these are the stem cells, are sometimes referred to as bone marrow transplant. And we know it's effective in early cerebral disease. This is a paper that Asif Mahmood put together with our group and Charlie Peters, who kindly shared his data from the University of Minnesota, comparing transplanted and non-transplanted individuals. And you can see that transplanted individuals stabilize compared to non-transplanted individuals. If you look at the years from the first abnormal MRI, a significant percentage of non-transplanted individuals will have died, whereas transplanted individuals will stabilize and have a survival rate of approximately 92 to 95%. Again, transplant, though, has a significant morbidity and mortality to the procedure. And at this time, when we wrote this paper, which is, 10, 12 years ago, and the data was even older than that, transplant-related mortality was 14%. Certainly, because of that transplant-related mortality, sometimes referred to as TRM, it's not indicated in asymptomatic boys. We said that only a third of boys will develop cerebral disease, so that if you're going to subject all males with adrenal leukodystrophy to this, you are going to potentially injure a significant percentage of individuals who are not going to develop childhood cerebral disease. And as it's become clearly obvious from the whole meeting and the whole purpose behind newborn screening, best candidates are routinely screened individuals known to be at risk. This is just some further data kind of honing in on this. This is a paper by Wes Miller and the group at University of Minnesota, and it was they looked at the University of Minnesota's experience, who clearly has probably the largest experience in the world doing bone marrow transplant for adrenal leukodystrophy. And what they showed was the probability of survival after bone marrow transplant, here as HCT for hematopoietic cell therapy, for the entire cohort of boys, which was 60 individuals at the time, was approximately 76%. And that doesn't sound as good as the Peters paper, but you have to understand that it was more all comers. So let's just kind of go look around at the data a little bit more closely. So if you look at this graph A, and again, the MRI score, sometimes referred to as the Less score, named after Dan Less had devised it when he was working at the University of Minnesota. Less score less than 10, now considered generally the low risk group. And we'll get in, as Sarah kind of alluded to, we're thinking that that's still probably too high, but it's the cutoff that was used, less than 10, 30 individuals. Their survival was much better than those individuals who had significant MRI lesions. So less scores greater than 10. Similarly, if you looked at in graph B, if you looked at individuals who had neurologic functioning scores of 0, that means no findings, no vision issues, no attention deficit, no language issues, no auditory processing issues. It basically, essentially asymptomatic individuals. They may have some neuropsych issues, but they are walking, talking concerns. Those individuals had excellent survival. You start to develop NFS of 1. You have a deficit. you're now in a much slightly worse spot. Still can be transplanted, but we would recommend that you be transplanted in a center that's used to dealing with those kinds of individuals. Your survival is going to be somewhat less. Well, this is what we're aiming to avoid here, though. And clearly, if you had more than one a deficit, you had a significant concern. The other thing I want to point out is here on graph C, is that if you had a LES score less than 10 and had a related donor, you survive. A related donor is typically a sibling, and all of those individuals survived. Some individuals still with a LES score less than 10, but an unrelated donor had some mortality. And I'm not going to, that's what I want to cover on this slide. Looking at a slightly different data set, we looked at individuals for their neurologic outcome. And again, this is a historic data set. It's not sort of the present climate, but this is over a number of years. We pull data from a lot of different bone marrow transplant centers, and your change from your baseline neurologic function scale, your NFS, depended on where you started. So individuals who started with an NFS of 0 could have some progression, but had very minimal progression. Individuals who had NFSs greater than 1 had significant progression and would have much more likelihood of a major functional deficit. So these are individuals, and so that's why it always gives us concern if an individual comes to us with already symptoms, whether they be vision or auditory processing or worse, both. Those individuals are not going to do generally well with transplant. This is Dr. Pierpont's data, and the numbers again become somewhat smaller, but and this is a published paper, and she presented more of this data yesterday, is that if your LES score now, your MRI severity score is less than 4, and we're getting to the point where we want to see it less than 2 or 3, your neuropsychological outcomes were certainly better than if you had a more involved LES score. So individuals with a LES score of 4 were more likely to have deficits in terms of their outcomes. You may not see them from across the room, but these are individuals who still may need some school supports, some supports in the community, and may not be able to have completely be independent in their living. So just to kind of give you some context, Eric had shown some of this. This is a LES score probably of approximately 2. This is what we want to see. We do not want to see that overly involved LES score of 7, 8, 9. That is not desirable. And this is our goal here with newborn screening, is to transplant, if we're going to transplant individuals, to get them quickly to transplant, and to do so as expeditiously as we can possibly do. So I just want to touch on one other thing, is that we do know that some individuals with AMN will develop cerebral disease in their adult years. The percentages vary, and this is one of the things that I'm really hopeful that the next 10, 15 years, we get much better numbers knowing what the actual incidence is of cerebral disease in men. It has been used. Bone marrow transplant or hematopoietic stem cell has been used in cerebral disease. The experience is smaller. We're still sort of feeling our way. I feel like as someone who's kind of been around transplant in ALD for quite a number of years, I think back to the early years of doing it in the boys, and we're still kind of trying to figure out who should receive this. It does arrest disease, but it's not a reversal. It's still unclear if the MRI precedes disease. There's a lot of morbidity, which is injury in individuals who already have significant myelopathies. So if you have walking difficulties, bladder incontinence, that makes it very difficult to get you through a transplant without a lot of significant injury. Okay. Now, one of the things you hear about when we talk about transplant is the match, and what does that actually mean? Well, it's more complex than just matching blood types. There's these human leukocyte antigens, and I will be the first to admit I still do not completely understand HLA matching, and I'm not a transplanter, and so if you have questions about that, I'm going to say we'll put you into contact with someone. But there's 6 basic HLA markers. They look at these, and a good match is 6 out of 6. I think it's actually 8 out of 8. There are other markers that get used. They vary by ethnicity. So if you're an individual who is, because we're all individuals, but if you're an individual who is not the typical Western European Caucasian individual, you may have less possibility of finding a match. And so I pulled this off of the National Registry, and your likelihood of a match varies very much. It can be anywhere from 1/3 to almost 80%. And if there's any transplanters on, I'm happy to defer to them. But the best marrow transplant outcomes occur when the recipient and a donor are closely matched. So again, how can we do that? Well, one of the things you could do is just make sure you come from a very large family so that you have a sibling. But we don't all come from families of having 4 or 5 brothers or sisters. Many, modern families are 1 or 2 individuals. You can, and there's been a process and a program now to collect unrelated donors. And so you will sometimes see campaigns for Be the Match. And this is from the National Marrow Donor Program. They would love you to be the match, sign up. But you're not signing up just for adrenal leukodystrophy. You're signing up for individuals who may have leukemia or aplastic anemia or a variety of other things. Also, unrelated umbilical cord blood. Remember, I said they're chock full of stem cells, and so these unrelated umbilical cord bloods can be the match. And now there's processes to pool these. They're perfectly adequate, and again, they're perfectly adequate if you're a child because you don't need a lot of stem cells. But they're not as good if you're an adult. There is a program, and I will say that it's been pioneered at Johns Hopkins, is using haploidentical. And so this is a process to increase the pool of possible donors. And so you can use a parent. It has its own risk and procedures that need to be done around it because you are going to expect to get some, what is referred to as graft versus host disease, some attack of the immune system because that's not you. And so they have to come in with immunosuppressive agents. This has been done rarely for adrenal leukodystrophy, but it is an option. But what would be the best or different, or at least add to something in our armamentarium? Well, what if the patient himself could be his own donor? And that brings me to a few slides talking about gene therapy and adrenal leukodystrophy. And again, I probably misspoke when I said best. It is something that is here to potentially increase our ability to treat certain individuals. Well, how would we do that? Well, the way this works is we isolate target cells from the patients. These stem cells are called CD34 stem cells. It's a way we mark them. We know that they're the stem cells. We don't actually know where the true stem cell is, but the CD34s have enough potential to be the stem cell. They get transduced with a viral vector. So when you take them out, they become, and then you basically infect them with a virus, the capsule that has the gene. And there's a lot of technical issues around that. You then have to check them and make sure that they're working. And unfortunately, we still have to do some making of room. That's called myeloablation. And initially that was busulfan and cyclophosphamide. There has been some tweaking of that, but that's a transplanter's art. The decision which agents to use, but these are strong chemotherapeutic agents. And so there's a lot of concerns that when you use a strong chemotherapeutic agent, you may be setting someone up for a cancer risk down the road. And not just in their stem cell lines, but their lungs, their brain, and other tissues. But now, be that as it may, this is a life-threatening disorder. We are looking for stabilization. We infuse these modified hematopoietic stem cells, and then we follow the individual along. This has been done. This has been done in adrenal leukodystrophy. Dr. Eichler and others. I think I'm on this paper as a worker bee. We did do this in boys with adrenal leukodystrophy and early cerebral disease, and in a number of individuals, we had stabilization of disorder. So this was 17 individuals. 12 individuals had no adverse neurologic features. Approximately 4 individuals, with one being relatively severe, did have worsening of their neurologic scores, probably equivalent to bone marrow transplant, although there's other studies presently ongoing that are looking at this sort of head to head. And so this is still at a early stage. I think we're going to hear some more about this program a little bit later today. So in summary, and I think I'm going to finish on time, bone marrow transplant or hematopoietic stem cell therapy is effective for arresting cerebral ALD at an early stage. The best individuals are those with no clinical symptoms, minimal but active MRI findings. We clearly need improved tools for detecting early cerebral disease. We want to be there when it's occurring, but not too soon. So we don't want to do it in asymptomatic individuals unless we can somehow change the process and make certain that our outcomes were 100% efficacious with no risk, but we're not there yet. Outcomes depend on multiple factors, but one of these is the HLA match. Gene therapy is potentially alleviating the need for a matched donor, but we're still in our early stages of understanding. And we really do need to understand better. There was a question yesterday about the long-term outcomes from bone marrow transplant, and would you develop adrenal myeloneuropathy? And there's, I think what it looks like and how it affects these young men now is something that we owe them to know better as time goes on. We still have some very big unmet needs. While newborn screening is wonderful, we still have individuals who come to us with significant cerebral disease. They've not been screened at birth, and they're coming to us, and we still need therapies for them. We also need therapies for adults with cerebral disease, because not every individual can undergo a stem cell therapy at this point. I think that's my last slide. I can't see the chat, but I am happy to take questions.
Thank you for pinch hitting, Dr. Raymond. We appreciate it. There is one question from Ali Giordano, whose hand is raised.
Mm-hmm.
I believe, there we are.
Oh. Hi, how are you?
Good.
Never used Zoom before, so forgive me if I'm a little nervous. Dr. Raymond, the newborn screening, it seems to be the only way we're going to find out, because when I found out it was too late, I went for a bone marrow transplant like not even 2 months after my son was diagnosed. And I went to Duke and they said he wasn't a candidate. And, they were very nice, very compassionate. I think Maria Escalar, just as texting her, she was one of the ladies that evaluated my son. And I remember when I got the diagnosis, I was just crying like crazy. And I think it was Dr. Passad that was there, whatever. They gave me like 3 to 6 months. They said he would never make his 8th birthday. Well, the grace of God, he's still here. He's 22 years old. But what I find so hard to, I went for the bone marrow. I called for the Lorenzo's oil. Nothing, everything was happening too quick. I just wish there's a way. I think the only way we're going to find out is through newborn screening. But you were saying that you have to wait till they don't show, like my son wasn't really showing symptoms until it was too late. Like I knew he was hyper. He was all over the place. And I took him, they told me he had ADHD. They said maybe he has ADHD. And then, I put him on medication for a minute and it wasn't that. And by the time when we really found out, it was like, I was doing everything possible to try to find out what was going on with him. He was so hyper. I used to tell people Steve was the perfect poster child for birth control because he was so hyper, but it was this happening. And it turned out he has Cerebral X-linked to me. Nobody in my family has it that I know of, but then, I'm a biracial child myself and my son was biracial. So as he was getting a little darker, I just thought it was normal. And now that I look back and see like how one side of his face was changing. But I just want to say, it's just been a really tough road and he's still hanging in there with me. Matter of fact, he's sitting right here with me. It's my beautiful boy right here. And the ALD community has been really great. I've been trying to come to the meetings when I can. Right now, I don't have a nurse, so I'm stuck in the house. Steve had COVID, but he's still here. But I just want to say the newborn screening is so, so important. And if Stevie should pass away, I really want to donate his body to science so they can study more because he's a miracle, 15 years plus with no bone marrow transplant, nothing. So I just want to say thanks Alicia for always trying to make sure this gets passed.
No, thank you very much for sharing that has been the impetus behind those of us who have worked so hard to get newborn screening going, and I've worked and I really continue to advocate to make it successful. We need to hear stories, unfortunately, like that. And I continue to have individuals come to me with advanced disease and it's heart-wrenching. And so the more we can advocate and get our stories out there, I think hopefully the better.
Thank you. Just thank you. And thank, the ALD community for being there for me through my struggles and the support, because mentally this takes a toll on you. And, my son is still here, but his father passed away 12 years ago at 43 from a heart attack because this was too much for him. But, we just got to keep hope. And I'm just breaking down for a minute, but I'm always positive. And I try to be there for other mothers that are just getting diagnosed, their sons are getting diagnosed, to let them know I don't look at what I don't have. I look at I still have. And Stevie smiles. He makes it worth it every day. And he's saying, hello, Stevie, say hi to everybody. Right now, he's making a little noise. I have to suction him. But I just want to say thank you. Thank you, Alicia. Thank you, all the doctors. Like you said, we just got to keep trying. And I just can't believe he's still here 15 years later.
Thank you.
Thank you so much, Lee.
All right.
Joe Orsini said, other than not requiring an HLA match, are there other advantages to gene therapy? And I want to thank Dr. Orchard too for hopping on to help field the questions.
Well, I think the advantages, the potential advantages are twofold. One is that it does increase the population. It does increase who we can offer to in terms of we don't necessarily have to have a match. Now, If you have a sibling match, I don't think any of us are ever going to turn that away. But the second potential reason is you're reducing the risk of what's referred to as graft versus host disease, which I didn't touch upon, but is one of the transplant-related morbidities. It's where the basically the cells that we're giving start attacking the recipient. And that can all be treated, but occasionally and rarely it is significant and can result in both acute and chronic diseases that can have downstream effects. I remember an individual who got transplanted who was asymptomatic, much to my protest. He insisted on it and developed an immune-based peripheral neuropathy, which was something he did not want. And so there are these kind of chronic potential things that can occur when you're giving someone else's marrow. Again, much less likely if you're giving a sibling, but potentially the gene therapy would reduce that risk. Now, gene therapy may have other risks, and we don't have enough, and we're still learning about that.
Yeah, Jerry, fine job as a transplanter there. You know. So I don't think there's any. I think it's very clear, essentially, that doing gene therapy, at least in the peri-transplant process, like out to 100 days or so, is much easier on the kids, and it's much there's less morbidity and probably mortality than you're going to see with allotransplant. There's the kids that are more advanced are certainly at higher risk. The kids that don't have great matches are at higher risk, and all those types of things. But it's much easier to do an auto transplant where you're giving your own cells back. You don't need immune suppression. The risk of infections is lower and whatnot. So, I mean, ultimately, what the late risks are going to look like, it's still something that we're kind of sorting through. As I think Stephanie's going to talk from Bluebird later today, so I don't want to precede that too much. But I mean, there are a couple of kids that have had a pre-leukemic situation afterwards, and so how that's going to evolve ends up being another question. But like I say, it's certainly easier to get the kids through an auto transplant than an allo transplant, meaning using somebody else's cells.
Mm-hmm.
Thank you. The next one is, there was an interesting presentation on cerebral visual impairment at the ALD Connect meeting. Sometimes boys can present with perfect visual and hearing acuity, but still have underlying process issues that might be harder to identify. For families that have not yet developed cerebral disease and are monitoring, would it be recommended to have a more thorough visual and hearing screening periodically?
No, I'm going to argue no. At least from what we presently know, now, whether increasing research data shows that you can detect anything prior to MRI lesion, I think is something we don't know. I will say that things like auditory evoked potentials are not useful. But what I am completely relying on is that early MRI lesion, and that's our gold standard at that point. I think these are all interesting questions, but I don't want the boy to become somehow symptomatic. I want to catch it at a very early stage when all I see is an MRI lesion, and all the tools I use in my toolkit, whether it be neuropsych or visual fields or all that stuff, is still very normal, and that's the boy we wish to send a transplant.
And if I can just chime in here too, so, and Jerry's the neurologist and Eric and others here, but the vision issues aren't the eyes, right? So if you're going to see an ophthalmologist, they may say your vision looks fine, but you may have lesions in your brain. And hearing is similar. I mean, your hearing may be fine from the standpoint of tones, for instance, but being able to understand language is a different set of issues. So those things you may pick up a little earlier with a neuropsych-based test, but the standard kind of screening stuff, I'm not sure is going to be as helpful for those things.
Right.
Is that fair?
I think it gets into a research basis, and there are tools that are used by sort of neurocognitive scientists that can look at the perceptual, and there's some electrophysiologic things. But I think, until we do sort of and the trouble is some of these tools are very hard to use, such as, for instance, visual evoked responses are pattern shift, and they're hard to do in 3 and 4-year-olds. So you got to pay attention, you got to do things like that. And so they're never going to be used. They're going to be used in older individuals. And it's just much more straightforward to use the MRI.
Yeah, I would agree. For the detection of disease, it's MRI. I think there is a place for doing more advanced vision testing, but as Dr. Orchard said, it's not the eye, it's the ability for the wiring to resolve the image. So the metaphor I use is, if you think of those old camcorders we all used to have that have a little screen on it folded out, the lens works just fine, but once the light gets into the signal to display it on the screen, which is your cortex, the signal gets jammed, and what gets displayed on the screen, which is what you experience in your vision, that signal is disrupted. So everything kind of gets into the eye, which is the lens, but the representation of the world, which is what you experience using your cortex, that gets scrambled. So and I think I saw Rini put a comment in here, from a prognostic from a prognostic standpoint, that may be helpful. And I know, Katie, maybe you can mention this. I know you guys are looking at cognitive visual impairment at MGH. So there is work ongoing, but from a screening perspective, I don't know that I agree. I don't think it's helpful, and it's practically difficult to do.
Okay, we're almost at 12:30, and I want to try to get everybody at least an hour lunch break in here. So there's 2 questions left that hopefully we can address. And then do remember that we are going to hear from Bluebird Bio later today about the gene therapy. Is there anything that can be done with a less score of 20? Is there therapy available?
Unfortunately, no. For such an advance, I think that's just one of these things that we continue to struggle with, and I know people are making attempts at other immunosuppression, but unfortunately, I do not think that we have sort of an off-the-shelf therapy for someone with such advanced disease. We have tried. We have put individuals through quite a bit to try and mitigate this. I think part of it is that we do not have a myelin repair tool at the present time.
Okay. And then secondary long-term side effects such as cancer are also a risk with allo-BMT. Does it seem that this is a greater risk for gene? Well,
we don't know how that's going to play out. It's gene therapy is using is using much of the same preparatory regimen presently that we would, either busulfan, Cytoxan, or fludarabine and other agents. And so I think unfortunately there's going to be some risk, and the degree of risk is something that I think is something we're just going to have to find out. And I think Bluebird can discuss some of it this afternoon. Paul, do you have anything else to add?
Well, so I think one of the key questions there is, certainly having cells exposed to chemotherapy agents like busulfan and cyclophosphamide, those kinds of things could potentially increase the risk of cancers. There's no 2 ways about that. The risk is pretty low, and it takes a long period of time generally for those things to happen. But you're still going to need chemotherapy, at least for now, with the gene therapy piece, albeit maybe a little less intensive. The issue is more the virus is supposed to insert itself pretty randomly into the DNA of the cell. And we want it to get into the DNA of the cell because as the cells divide and grow, we want it to be passed along to all the daughter cells. So, that's an important component, but where it inserts itself is we don't have control over. And if it puts itself down next to a gene that it turns on that may drive cancer, that's the issue that's kind of distinct with the gene therapy side. So what the relative risk of that is going to be is, as Jerry was kind of alluding to, still unclear, but there are a couple of kids where this has happened. And so what the proportion is going to be in the big picture is still not clear. It may take us a few more years to sort that out.
Miranda, I the trouble with the chat is I can see it at the end. I see someone misunderstood about 50% of women. 50% of women do not develop cerebral disease. Cerebral disease in women is extraordinarily rare. 50% of women in their adult years may develop a neurologic finding, but it is usually in the AMN type spectrum with walking issues, bladder issues, some sensory issues. We rarely see any endocrine, any adrenal issues or cerebral disease in women. I apologize if I confuse people, but no, so we do not recommend routine MRI screening. And Katie Beck was also responded to that, but it's just, I just want to say it up front, out loud, that's not something we're routinely recommending.
Thank you. Thank you, Dr. Orchard. Thank you, Dr. Raymond.